Swayam Prabha. Digital India. Educated India.
Good day and a very warm welcome to all. This is Dr. Mauna Subbaramaya, working as Associate Professor at Kempegowda Institute of Medical Sciences. So today we will be discussing about the general layout plan of the GI tract, and we will be dealing with the histology of esophagus and stomach. So let's begin the session with a typical exemplification. So could you answer this question which I am just projecting? So what is pernicious anemia? So I guess most of you all know the answer to this. So pernicious anemia is nothing but a condition which results in the decrease of RBCs, which is in turn due to the deficiency of vitamin B12. And why does this occur? It's usually because of the deficiency of the intrinsic factor which is associated. So this intrinsic factor, it binds with the vitamin B12 and it's then absorbed. So if there is a deficiency of the intrinsic factor, then the absorption of vitamin B12 will be blocked. So all of you all know what this is about. But as a medical student, you should know what pathology in the gastrointestinal tract causes pernicious anemia. So here's a small clue. So I guess at this stage you are not able to identify. So if you know what cell is this, where is it located, what are its functions, and what happens when it is destroyed. So there is some connection between this cell and pernicious anemia. So in today's session, we will see injury to which cell results in pernicious anemia. Okay. So we will be starting with a general layout plan of the GIT. Then we will be subsequently proceeding to the histology of esophagus as well as the stomach. So the gastrointestinal tract is a tube, alimentary canal it is referred to as. The primary function of this is digestion, absorption and secretion of nutrients. So it extends from the oral cavity to the anal canal. So these are the individual parts which constitute the alimentary canal. So it includes the oral cavity, the pharynx, the esophagus, the stomach, the small intestine, the large intestine, the rectum and anal canal. The small intestine comprises of the duodenum, jejunum and ileum. And the large intestine has a cecum and appendix and the colon. The colon is ascending, transverse and descending colon. So all these parts constitute the gastrointestinal tract. Now when we talk about this segment of the gastrointestinal tract, that is starting from the esophagus to the anal canal, the wall of this particular segment has following common features. They have some similar features which are present in this entire extent of the tube. So that is what we will be studying in the subsequent slides. And actually speaking, the region between the stomach to the rectum is what constitutes the actual GI tract, because this is concerned with the digestion, absorption and secretory process, whereas the other units, that is the esophagus and the anal canal, they act as the input as the output channels. So coming to the general layout plan, so from the esophagus to the anal canal, the tube has the common layers which are present. So what are these layers? The first layer is the mucosa, and this in turn is made up of three units, that is the epithelial lining, the lamina propria and the muscularis mucosa. So adjacent to this, just beneath it, is the submucosa. So, because it lies beneath it, it is called a submucosa. This region is made up of the connective tissue zone, which connects the mucosa to the external layer. So, what is the external layer? That is the muscularis externa. So, this unit, it either comprises of the striated muscle fibers or the smooth muscle fibers. So, there are usually two layers, and in some places there can be an additional third layer which is present, like in the stomach, which we will come across. So, this is a predominantly muscular layer, and the muscles predominantly being smooth muscles, except for a few places where it can be striated. The same thing holds good for the muscularis mucosa of the mucosal region as well. And the last and the outermost layer is the serosa or adventitia. So, this layer is referred to as serosa when it is associated with peritoneum, and when it is associated with the adjacent fascia, it is referred to as adventitia. So, these four layers form the basic units of the wall of the GI tract. We study these layers as a common entity and then find the differences appropriate to that particular region. So, if we are aware of these, we can identify all the slides of GI tract. So, we will study these layers in a little more detail. So, what do we see in the mucosa? Mucosa, the innermost lining of the mucosa is referred to as the epithelial lining. Now, this epithelial lining can vary from region to region, this based on its function. So, it can either be stratified squamous non-keratinized epithelium, it can be columnar epithelium. So, depending on the function, the epithelium varies in different segments. So, the primary functions of the epithelium are protection, secretion and absorptions, and I mean in the secretory unit there are associated glands which are present. So, to supplement, so most of these lining epithelial cells are responsible for secretion of some or the other substance. So, to aid the secretion of these epithelial cells, what we have is an additional modification of these epithelial cells, that is the presence of glands. So, these glands can either be mucosal glands, submucosal glands, or they can be entirely present outside the wall itself. So, these are the bigger glands which we are referring to, that is the liver, pancreas or even the salivary glands. So, all these glands are present outside the canal. The other two are present within the walls of the GI tube. So, that is the submucosal glands which are present in the submucosal region, and these are typically seen in two segments of the GI tract, that is the esophagus and duodenum. The rest of the glands are predominantly mucosal glands which are present in the lamina propria region. Okay. So, this was about the epithelial lining. So, the lining epithelium depends on the function. Coming to lamina propria. So, this is a loose connective tissue zone just adjacent to the epithelial lining, and it is made up of delicate fibers of collagen, elastic and reticular fibers. And the predominant function of the lamina propria is to connect the mucosa to the external muscularis mucosal layer. So, this is a thin connective tissue zone, and it also provides protection to some amount, because there you have the connective tissue cells which act as a defense mechanism. And it also provides some amount of nutrition through the blood capillaries which are flowing through it. And the third layer of the mucosa is the muscularis mucosa. So, like the muscularis externa, this also can comprise of striated or smooth muscle depending on which segment, but predominantly it is made up of smooth muscles. And these smooth muscles, they are arranged in two layers, that is the inner circular and the outer longitudinal. And what is the function of this muscularis mucosa? So, one, they alter the surface configuration of the mucosal lining. So, whenever we open up any part of the GIT, there are certain folds which are present. So, all these refer to the surface configuration. So, these are produced by these muscularis mucosa. And they also allow for the local mixing of substances. So, as the substance is passing through certain segment of the canal, there is some amount of local mixing which is brought about by the muscularis mucosa. Note here, the peristalsis is not brought about by the muscularis mucosa because it is not that powerful. Okay. It is only the local mixing which the muscularis mucosa engages in. And in segments like the small intestine, it helps in the milking of lacteals because it extends into the villi which is present. And also it aids in the secretion of the glands of the lamina propria. So, these are the primary functions of the muscularis mucosa. So, it alters the surface configuration, it allows for the localized movements, allows for the milking of lacteals, and it also results in the secretion of the glands in the lamina propria. So, this was about the mucosa with the 3 layers. You have the epithelial lining, the lamina propria, and the muscularis mucosa. So, epithelial lining will vary according to its function, the functions being protection, secretion and absorption. Then you have lamina propria, which is a connective tissue zone, again acting as mechanical support, helping in protection and nutrition, and muscularis mucosa, which alters the surface configuration, helping in secretion of glands, milking of lacteals and so on. So, this was about the innermost layer, that is the mucosa. So, the next layer is the submucosal area. So, this is the submucosal region just adjacent to the muscularis mucosa, and it is again made up of a connective tissue zone. So, it kindly resembles like the lamina propria, but it is a little coarser. So, the fibers which you find in this zone are a little more coarser compared to the lamina propria, and also the blood vessels and nerves, they are a little bigger compared to the lamina propria. So, this is a zone which is around the mucosa, and it is made up of loose connective tissue, and there are a predominance of elastic fibers in this particular zone. And there are also blood vessels, lymphatics and nerves and glands. So, these glands I am particularly focusing on 2 segments of the GI tract, that is the esophagus and duodenum. Elsewhere they are concentrated in the lamina propria region only. So, except for these 2 places, the other glands are usually situated in the lamina propria. In these segments, because you need extra secretion, you have extra glands in this particular zone. So, adjacent to the submucosa, we have the next layer, that is the muscularis externa. Now, this is 2 layers which has been shown, one in a purple layer and the other outer one in a yellow layer which is dotted. So, the inner it is usually arranged in an inner circular fashion and an outer longitudinal fashion, and like previously mentioned, it comprises of both striated muscles as well as smooth muscles. The upper part of the esophagus and the lower part of the anal canal, they are made up of striated muscles and they are voluntary, whereas most of the segment is made up of smooth muscle cells. And in addition, some segments will have an additional layer, that is the oblique layer, which we come across in the stomach. So, apart from these smooth muscles or striated muscles, we have the connective tissue fibers which intervene between them, and we have the nerves and vascular plexus in relation to the muscularis externa. And what is the function of the muscularis externa? It is the peristalsis. So, the arrangement of this smooth muscle cells and their alternate acting will propel the food downwards into the GI tract. Okay. So, when the circular muscles act, they cause constriction of the lumen. When the longitudinal muscles are acting, they shorten the tube. So, these act alternatively to propel the food forwards, and almost the action comes in a spiral fashion. So, when one segment is active, the other is relaxing. So, that helps in the propulsion of food. The outermost layer is the serosa. So, this is the outermost layer, and depending on whether it is related to the peritoneum or not, we have the definition as serosa or adventitia. So, if there is a peritoneal lining present, then it is serosa. So, this has a small connective tissue zone with the mesothelial cells, which are nothing but squamous cells. But if there is no peritoneum which is involved, then the outermost layer blends with the surrounding fascia, and here it is referred to as adventitia, and here it is typically made up of huge bundles of collagen fibers. So, usually the intra-abdominal part is related to the peritoneal lining. So, most parts of the GI tube within the abdomen are covered by serosa, except for posterior aspect of the duodenum, which are retroperitoneal. So, those areas which are not related to the peritoneum will be covered by adventitia, and also the thoracic part of the esophagus, etc. So, these are the 4 primary layers of the GI tract. So, to repeat, we have the mucosa, we have the submucosa, we have the muscularis externa, and lastly the serosa or adventitia. So, if you are aware of these 4 layers, you can identify any slide of the GI tract. So, next coming to the nerve plexus. So, there are 3 nerve plexes chiefly which are present in the wall of the GI tract. So, these include the myenteric plexus or the Auerbach's plexus. Now, this is present in relation to the muscularis externa. So, between the outer longitudinal and inner circular, we have this myenteric or the Auerbach's plexus. Then we have the submucosal plexus or the Meissner's plexus, which is present in the submucosal region. In fact, it is on the submucosal surface of the muscularis externa. That is where this plexus is actually located. And in some areas we find this mucosal plexus, which is nothing but a derivation of the submucosal plexus itself. So, these 3 plexes are present in the wall of GIT. To repeat, the myenteric, the Meissner's and the mucosal. So, what is contained in each of these plexes? So, you have the sympathetic and parasympathetic nerves, but the cell bodies are predominantly the parasympathetic cell bodies. So, we see that when in parasympathetic segments, the preganglionic fibers are long, whereas the postganglionic are very short, because the cell bodies are situated very close to the viscera. So, these have the cell bodies of the parasympathetic, but the nerve fibers will include both sympathetic and parasympathetic. And what is the effect of the sympathetic activity? It reduces the peristalsis, it stimulates the sphincteric action, and it stimulates the muscularis mucosa. The opposite holds good for the parasympathetic. So, here you have increase of peristalsis, the sphincteric action is reduced, the muscularis mucosal action is reduced, however, the gastric secretion is increased. So, these are the effects of the parasympathetic activity. So, these nerve plexes are in relation to all the parts of the GIT. So, with this brief introduction to the GI tract, now let us move on to the actual histology of different segments of the GIT. So, in today's session, we will be talking about esophagus and stomach. The subsequent regions will be dealt in subsequent sessions. So, coming to the histology of esophagus. So, this is a picture which you observe under a microscope. So, just by the look of it, you will be able to identify the few layers. So, just to make it simpler, I will be using the same diagram which I used for the general description, and try to correlate each layer to this microscopic picture. So, we will start with the innermost layer, that is the epithelial lining of the mucosa. So, this portion which is shown in dark region, that corresponds to the epithelial lining. The next zone is the lamina propria, which corresponds to the immediate layer beneath this epithelial lining. So, this darkened pink region or the intermediate one between this oviductant and the lighter version. So, this region corresponds to the lamina propria. And the next segment is the muscularis mucosa. So, you find a thin zone of this muscle layer here, it is better appreciated here. So, this corresponds to the muscularis mucosa. Subjacent to this, you find the submucosa with a few glands which you can make out here. Like I previously said, the submucosal glands are very predominant in esophagus. Then we have the muscularis externa layer. So, this is the inner circular layer and that is the outer longitudinal layer. And the outermost layer is the adventitia, or the intra-abdominal part of the esophagus can be covered by serosa. So, these are the layers, the corresponding layers which you see in the microscopic picture of the esophagus. So, this is an enlarged version of the same for a better view. So, that is the mucosal region, that is the submucosal region, that is the muscularis externa, and we have the adventitia or the serosa. So, we will start with the mucosal region. So, mucosa comprises of the three units. The first one is the epithelial lining, the second one is the lamina propria, and the third one is the muscularis mucosa. Okay. So, this is better appreciated in this segment. So, that is the mucosa, the epithelial lining, that is the first one. So, what is the epithelial lining in case of the esophagus? So, here the primary function of the esophagus being protective in nature, because it is just acting as a transit tube, it is lined by stratified epithelium. So, these cells are placed one over the other, the basal cells being columnar, then they become polygonal, and then they become flatter and flatter with the superficial flattened squamous cells. So, it is stratified squamous non-keratinized epithelium, non-keratinized because it is not exposed to any dehydration. So, it is stratified squamous non-keratinized epithelium which is present in the esophagus. So, adjacent to that we have the lamina propria region, which is made up of typical loose connective tissue with delicate collagen, elastic and reticular fibers. You also find defensive cells like the lymphocytes, the WBCs, the eosinophils. Okay. So, these are present in this particular zone, and also delicate loops of capillaries and nerve plexus are also encountered in this segment. And the third layer is the muscularis mucosa. So, like I said, the upper segment of the esophagus may have striated muscle fibers, but as you come lower down it will be the smooth muscles, and these muscularis mucosa, they are arranged in two sets, the inner circular and outer longitudinal. So, all these three segments will constitute the mucosa, and below this we have the submucosal region. So, coming back to this picture, so we finished with the mucosa. The next region is the submucosa. So, here the typical feature of the esophagus is the presence of these glands, the submucosal glands. Now, these are racemose or compound glands which insinuate between the muscularis mucosa and go and open into the lumen through the epithelial lining. Okay. So, these glands are there to provide extra secretion for lubrication as the food is passing through the esophagus. So, these are the submucosal esophageal glands. So, you can find n number of glands which are present in the submucosa, and the other components of the submucosa are the same, that is the connective tissue, the coarser connective tissue with the bigger blood vessels and nerve plexus, and the connective tissue cells as well, which are present. So, outer to this we have the muscular layer, that is the muscularis externa, and like the muscularis mucosa, this also the upper part will have striated muscles, whereas the lower part will have smooth muscles. and this is usually arranged in inner circular and outer longitudinal. The outer longitudinal coat is thicker in case of the esophagus than the inner circular layer, and it forms a complete circle around the wall. So, this part of the esophagus, that is the muscular externa, it is uniform throughout the segment except in the upper part of the esophagus, where this longitudinal layer diverges and it forms a tendon and gets attached to the anterior part of the cricoid cartilage. So, the anterior aspect of the lamina of the cricoid cartilage. So, the upper aspect, there is a small tendon being formed and two longitudinal fasciculi which go and get attached. The inner circular fibers, they become continuous with the inferior constrictor of the pharynx above, and below they become continuous with the oblique layer of the stomach. And at the junction of the esophagus and stomach, there is no thickening of the smooth muscles as such, but there exists a physiological sphincter. So, any dysfunctioning of this physiological sphincter can result in a condition called as reflex esophagitis, that is the acidic contents from the stomach can reflux into the esophagus and denude the mucosa. But note that there is no anatomical thickening of this muscular layer in this zone. It is only a physiological sphincter which is active here. Okay. So, this was about the muscularis externa, and in between these two layers you find the myenteric or the Auerbach's nerve plexus, and in the submucosal region you find the Meissner's plexus. And the outermost layer is the adventitia, which is again made up of collagen fibers, and except for the intra-abdominal part which is partly covered by peritoneum, and there you have a typical connective tissue lining which is overlaid by squamous mesothelial cells. So, most of the esophagus is covered by adventitia which blends with the surrounding fascia. So, these are the four layers of the esophagus which we have discussed. So, what are the important features in esophagus regarding the mucosa? It is stratified squamous non-keratinized epithelium. Then the other two layers are present as usual, but you can have a few striated fibers. In the submucosal region, you find the submucosal glands which are present. And the important entity for muscularis externa is the outer longitudinal layer being thicker compared to the inner circular layer, and it forms the longitudinal fasciculi in the upper part. So, this was in brief about the histology of the esophagus. So, we will just list up a few clinical anomalies or implications with regard to the esophagus. So, I will be just portraying a few endoscopic pictures which we can correlate with pathological pictures. I did not want to put up the pathological pictures because it might be a little confusing at this stage, because you are yet to start the normal anatomy, and if you see too many slides it might be a little confusing. So, I just thought as a broad overview we will put up a few endoscopic pictures instead. So, this is a case of esophageal candidiasis. So, here the mucosa will be denuded and there is a lot of exudate inflammation which is present here. So, the exudate, there is a white exudate collection in the outer aspect of the mucosa. So, this is an infection, fungal infection, which is very common in immunocompromised people. Next is the esophageal varices. So, you can see the bulging of the mucosal surface of the esophagus. This is due to the underlying veins which are dilated, and this commonly happens in portal hypertension. So, it may eventually rupture and cause bleeding. And here we see a growth of the esophagus, which has to be confirmed by biopsy whether it is benign or malignant. So, a growth can be seen in this particular picture. And next, but most commonest, is the condition the reflux esophagitis. So, this is commonly referred to as GERD, gastrointestinal esophageal reflux disease. So, gastrointestinal reflux disease. So, if this in this condition the acidic contents of the stomach will regurgitate into the esophagus and irritate the mucosa here, and as a result this mucosa gets destroyed and can result in either ulceration, or it can also lead to change of epithelium. So, this change of epithelium from one to another is referred to as metaplasia, and this is commonly seen in a condition called as Barrett's esophagus. So, if GRD is left untreated for a long time, then it can result in either ulceration or in Barrett's esophagus, where the epithelium changes directly from the stratified squamous non-keratinized epithelium into columnar. Usually the segment which is very close to the stomach becomes columnar. So, that is the change of epithelium, sudden change of epithelium which we observe between the esophagus and the stomach. But if this change occurs or extends into the mucosa of the esophagus, then we call this condition as Barrett's esophagus, and there are higher chances of ulceration and cancerous changes if left untreated. So, this was in short about the esophagus. So, our next topic is stomach. So, stomach is the most distensible part of the gastrointestinal tract. The main functions of the stomach include: it acts as a mechanical mixer, it acts as a chemical digester, and it acts as a temporary storage receptacle. So, the primary functions are the digestion and absorption, and also it might act as a temporary storage receptacle for certain materials. So, coming to the parts of the stomach, it has a cardiac end and a pyloric end, and it has a lesser curvature and a greater curvature. So, it is a J-shaped structure. So, you have a lesser curvature and a greater curvature. This is the pyloric end, this is the cardiac end, the upper end, and this is the pyloric end, that is the lower end. And the surfaces include anterior-superior surface and posterior-inferior surface. So, if this is the stomach like this is the lesser curvature, greater curvature, anterior superior surface and posterior inferior surface. So, this will continue with the esophagus, this will continue with the duodenum. So, if you have to divide the stomach as such, so this is the cardiac end of the stomach, then you have the fundus. So, if you draw a line, imaginary line cutting across the cardiac orifice, the region of the stomach above that is referred to as the fundus. The next is the body, and along the lesser curvature there is the most dependent portion called as incisura angularis. So, if you draw an imaginary line extending from this incisura angularis to the greater curvature, it divides the stomach into a proximal body and a distal pyloric end. And adjacent to this you might find a groove which will divide the pylorus into a pyloric antrum, which is a little dilated part of the stomach, and a narrower portion called as the pyloric canal. So, these are the different segments of the stomach, starting from the cardiac end and ending at the pyloric end. So, it includes the fundus, the body and the pylorus. Now, when we see histological aspects of the stomach, the fundus and the body are very similar in nature. So, we will be studying the stomach in two segments, that with the fundus and body, and a little different is the pyloric end. Okay. So, we will be seeing the differences between these two segments of the stomach in detail in the subsequent slides. And the cardiac portion of the stomach, it has a few differences which will be just summarized at the end. After studying these two in detail, we will be summarizing it along with the features of cardiac, because this portion constitutes to very minimal segment of the stomach, and it is not that relatively huge enough to be spoken in detail. So, we will be just summarizing it at the end. So, coming to the stomach fundic region. So, this is the microscopic picture of the fundus which we see. And to correlate it with the usual our favorite diagram, we will start from the innermost layer, that is the mucosal lining or the epithelial lining. So, this segment will correspond to the epithelial lining. The next is the lamina propria region, which has the glandular segment which is present, that is the muscularis mucosa, which is again made up of two layers, inner circular and outer longitudinal. Then we have the submucosal region, that is the adjacent connective tissue zone. So, you can see the submucosa extending here. Then we have the muscularis externa. So, in the muscularis externa we have three layers here. So, this is unique to the stomach. So, in addition to the outer longitudinal and inner circular layer, we have an additional innermost oblique layer in the stomach, and the outermost layer of the stomach is the serosa. So, these are the corresponding layers of the GI tract. So, with this idea we move on to the enlarged version. So, this is the mucosa, the submucosa, the muscularis externa and the serosa. Now, we have studied the esophagus from inner to outer aspect. Since the features of the outer aspects of the stomach are common to both the fundus and the pyloric end, we will first deal with the outer layers and then go on to the mucosal layer. So, we will start with the outermost layer, that is the serosa. So, there is nothing specific about the serosa. It is lined by mesothelial squamous cells with an underlying connective tissue zone. So, the covering is serosa, except for a small part of the stomach in the upper cardiac region on the posterior aspect, which is called as the bare area of the stomach. So, that region may be covered by adventitia, okay, because it is not related to the peritoneum. The next layer is the muscularis externa. So, like I said before, there are three layers here. So, it is outer longitudinal layer, the middle circular layer and the innermost oblique layer. The outer longitudinal layer, it occurs in two sets. One set, it starts from the cardiac end and ends at the pyloric end. The second set of longitudinal fibers, they begin in the mid segment of the stomach and go on extend into the duodenum. So, they become continuous with the longitudinal fibers of the duodenum. So, this was about the longitudinal set. The next set is the circular set, which becomes continuous with the circular fibers above in the esophagus, but they are not continuous with the segment of the duodenum. There is a connective tissue septum which is present between the circular fibers of the stomach and the circular fibers of the duodenum. So, there is a separation there, unlike the upper segment where it becomes continuous. So, the inner layer of the esophagus will become continuous with both the circular fibers of the stomach as well as the innermost oblique layer as well. And at the pyloric end, you have this segment, that is the inner circular fibers. They form a thickened aggregation of smooth muscles called as the pyloric sphincter. Okay. So, this has an anatomical sphincter here, unlike the esophago-gastric junction where there is only a presence of a physiological sphincter. This here in the pyloric region, there is actual aggregation of the smooth muscles which you can see, which acts as a sphincter. So, there is a presence of anatomical sphincter at the distal end of the pylorus. So, that is the inner circular layer, and the innermost is the oblique layer. Now, this layer, it starts at the cardiac end and it forms loops, U-shaped loops around the stomach, and the free margin of this loop is present along the lesser curvature, which actually forms the margin of a gastric canal. It is called as the gastric canal of Megen-Stress. So, that is nothing but the free edges of this oblique layer. So, this was about the innermost layer, and this innermost layer, it becomes continuous with the circular fibers of the esophagus above. So, the next layer is the submucosal region, where you find the usual connective tissue zone and the blood capillaries, nerve plexus, etc. So, these three layers, that is the serosa, muscularis externa and submucosa, are common to all the segments of the stomach. They are similar in appearance. So, that is why we have proceeded from out to in. Now, the segment which differs in structure is this mucosal region. So, when we open up a stomach, there are longitudinal folds called as rugae. So, these can be distensible. So, if it is filled, they disappear. So, these rugae are temporary and some of them can be permanent as well. And if you see the mucosa of the stomach, it gives a honeycombed appearance. That is because of the presence of gastric pits. Now, gastric pits are areas where the gastric glands are opening, and they can measure anywhere between 0.2 to 0.3 millimeters. So, there are lots of holes on the mucosa of the stomach. So, this gives a honeycomb appearance even to the naked eye. This is seen. So, this mucosa, you have the upper portion which is seen as gastric pits, and the lower portion which is seen as the gastric glands. So, this epithelial zone which is present here comprises of the pits. So, you can just open up those. So, the ratio of the gastric pits to the gastric glands is 1:3. So, in the fundic and in the body of the stomach, this is the ratio. The length of the gastric pit is, if you take that as 1, the gastric gland length is 3 times the gastric pit. So, the ratio is 1:3. And all the gastric glands are seen in longitudinal fashion. And subjacent to this, you find the muscularis mucosa region here. So, if we take a typical gland, so this is the secretory unit, the actual gland which is thing, and this is the outflow, the conducting unit, and this opens into the mucosa. So, you find different types of cells which are lining across this entire segment of the gland. So, this is called the base of the gland, this is called as the neck of the gland, and this region is referred to as the isthmus of the gland, the narrow portion which is referred to as the isthmus. So, what are the cells which we come across in the fundus of the stomach? So, the first and foremost number of cells which we come across are the chief cells. So, these chief cells are otherwise called as zymogenic cells. So, these are predominantly seen at the base of the gland, and they have typical pyramidal appearance or slightly cuboidal appearance with a slightly basally pushed nucleus, and there are lots of granules and attached to the endoplasmic reticulum, ribosomes, and this endoplasmic reticulum, it will give a basophilic appearance to the cell. So, this is the chief cell which is predominantly present at the base of the gland, and it is predominantly basophilic in nature. And what is the function of this? It secretes pepsin, renin, lipase. So, all these are functions of the chief cells, otherwise called as zymogenic cells, ZYMOGENIC, zymogenic cells. So, that is about the chief cells. The next variety of cell is the parietal cell. So, does this ring a bell? Yes, this is the picture which we saw in the first slide. So, this is nothing but the parietal cell, or otherwise called as auxentic cells, OXYNTIC, auxentic cells. Now, these cells are present throughout the gland, unlike the chief cells which are concentrated towards the base. So, these you can find anywhere across the gland, and they are usually bigger compared to the rest of the glands, and they are predominantly eosinophilic. Okay. And the other typical feature is they have the presence of the intracellular canaliculi. So, these canaliculi bear microvilli and which to increase the surface area, and they liberate or HCl. So, they have this enzyme carbonic anhydrase which helps in the production of HCl. And the other important factor which it secretes is the intrinsic factor. So, this cell is nothing but the parietal cell, or otherwise called as auxentic cells, responsible for the production of HCl and intrinsic factor. So, these are the two main cells which are present in different parts of the gland. The other cells include the mucus cells, which are predominantly seen in the neck region of the gland, and their function is to secrete mucus to help in lubrication. Then we have the argentaffin cells, which are enterochromaffin cells, and these are special cells which are stained by silver salts. So, that is why they get their name argentaffin, silver affinity. Okay. So, argentaffin cells, they also occupy different parts of the gland, and they are present predominantly between the basement membrane and the chief cells, and they are small pyramidal cells. And the last variety of cells are the stem cells, which give rise to the other cells. So, these stem cells are usually found again in the basal region of the gland. So, these cells are produced here and then they are pushed towards the superficial zone. So, to repeat, there are 5 kinds of cells in the stomach. They are the chief cells, parietal cells, mucus cells, argentaffin cells, and the stem cells. So, in a microscopic picture, this is how the glands look like, and this is the parietal cells, that is the pinkish ones, the big pink cells referred to as the parietal or the auxentic cells, which are responsible for the secretion of HCl and intrinsic factor, and the chief cells are the other basophilic cells which are lining the mainly the basal region of the gland, and these are responsible for secretion of the enzymes pepsin, renin and lipase, and chief cells are also called as zymogenic cells. So, the other cells we will not be able to see under the normal compound microscope which we usually use. They can be seen in higher versions of the electronic microscopes or ultra microscopes. Okay. So, this you will be able to appreciate in a normal histology lab. So, that was about the fundus. So, next moving on to the pyloric end of the stomach. So, the pyloric end of the stomach looks like this, and if we have to correlate it with the same diagram, I have an affinity for this diagram. So, this goes with the mucosa, that is the epithelial lining, then you have the lamina propria, then you have the muscularis mucosa, then you have the submucosa, the muscularis externa, and the outermost layer is the serosa, which was not seen in the previous diagram. So, this is the enlarged version of the stomach pyloric part. So, here we see distinctly the glands, that is the pits of the glands, and we see the glands which are situated in the lamina propria region. Now, can you make out any difference between the appearance of the glands between the pyloric end and the fundic end? Yes. So, here in the pyloric end, the glands are coiled over one another. So, you do not find them in longitudinal section. You will see many coils of glands. You can appreciate that very nicely here in this picture. So, you will find nice coils of glands. So, they are like rolled over one and a section is taken. So, you find multiple sections of the same gland. Unlike in the fundic, it is longitudinal section of one single gland which you were able to appreciate. And here the pits, the ratio of the pits to the glands is reversed. So, the pits are longer compared to the actual secretory unit. So, this is the mucosal region, the submucosal region, the muscularis externa region and the outermost serosa, and coming to the mucosal region we have, that is the epithelial lining which is seen as part of the pits, then the lamina propria which has the coiled portion of the glands, and the muscularis mucosa. Okay. So, this is another enlarged version of the same part segment, that is the mucosa. So, here you can clearly see the enlarged pits. Okay. Okay, so you can see the difference between the ratio of the gastric pits to the gastric gland. So the ratio is reversed. Now it is 3:1. So this was a segment which was seen in the fundic region where you see the longitudinal section, but here you will see these as coiled structures. So that is what I mentioned as the difference in appearance between the fundic glands and the pyloric glands. So the ratio of the pits to the glands is reversed, and here the coils are seen in the other section other than the longitudinal section. So what are the cells which you come across in the pyloric end? So you find the usual cells, but with a few differences. So these are the cells which you encounter in the pyloric part of the stomach. So there are n number of mucosal cells or mucus cells which help in secretion of mucin, which is responsible for lubrication purpose. Then we find a few parietal cells. So they are less in number compared to the fundic region. So as you come down, the parietal cell number decreases. And one important entity is you do not find any chief cells here. So the chief cells are only concentrated to the fundic region, they do not extend into the pyloric region. However, you do find a few argentafin cells. So almost all the cells are present except for the chief cells. The stem cells of course are present here as well. Except for the chief cells, the other cells are present, but with a few differences, that is there is an increase in mucus cells, but decrease in parietal cells. So these are the differences between the fundic and the pyloric part of the glands. So coming to summarize the differences between the fundus and the pyloric, and like I had mentioned earlier, I will be including the cardiac region as well in this part, because this has a little bit of region which extends onto the posterior superior aspect of the stomach. Since it is not that clinically important, I just thought I will put up in this table, it was more than enough. So we have the cardiac end, the fundic end, and the pyloric region of the stomach. So what is the differences in the glands? So in the cardiac region, it comprises of the short tubular glands, 1:1 ratio. So they are nice short tubular glands which extend into the lamina propria with the pits to the glands ratio as 1:1. Whereas in the fundic region, they are elongated tubular glands which can be J-shaped, and their ratio is 1:3. The pit to gland ratio is 1:3, and this ratio is reversed in case of the pyloric end. So there are coiled secretory paths which are seen unlike the longitudinal segments, and the ratio is reversed here. The pits to gland ratio is 3:1. Coming to the cells. So these are the cells which are predominant in case of the cardiac region, that is the mucus cells and a few parietal cells. In case of the fundic cells, you find all the 5 cells, that is the chief cells, parietal cells, mucus cells, few argentafin cells, and of course the stem cells. In case of pyloric end, there are more number of mucus cells, there are no chief cells, fewer parietal cells, fewer argentafin cells. And the muscularis externa, it has the cardiac region has inner circular and outer longitudinal. It does not have the oblique layer. So this is another distinctive feature of the cardiac end. It resembles more like a esophagus. The fundic region has 3 layers: innermost oblique, middle circular, and outer longitudinal, and this extends into the pyloric sector as well. So there is no difference between the fundus and pylorus in this part of the layer. So these are a brief summary of the differences between the parts of the cardiac, fundus, and the pyloric end of the stomach. So what we are seeing here in the picture is a growth in the stomach region, and this can be tumors, and often the tumors are carcinoid tumors which we encounter in the stomach. They are nothing but a proliferation of the argentafin cells which result in carcinoid tumors. So these are very common in the stomach area. And the next one is atrophic gastritis. So, when we speak of atrophy means destruction or a reduction. So, when this happens, atrophic gastritis, all the cells in the stomach mucosa tend to decrease in number, get destroyed, and their function is hampered. So, as such, even the parietal cells are also involved. So, the parietal cells are not able to secrete the intrinsic factor. Deficiency of intrinsic factor will result in deficiency of vitamin B12. So, this condition will cause pernicious anemia. So, this rings the bell. So, the picture, that is a parietal cell which is destroyed in case of atrophic gastritis, will not function, hence result in deficiency of the intrinsic factor, which in turn results in the deficiency of vitamin B12 absorption. So, this is the cause for pernicious anemia. And the other one is the denudation of the mucosa, which results in ulceration, and this is quite common. Peptic ulcers are the most routinely encountered cases in the medicine department. So, they can either be stomach ulcers or duodenal ulcers, and there are variation in the clinical presentation between the two. So, ulceration is denudation of the mucosal lining. So, with that we come to the end of today's session. So, we will just summarize what we have learnt in today's session. So, we studied about the 4 layers of the GI tract which are common to the entire tube, that is the mucosa, submucosa, muscularis externa, and the serosa or adventitia. We also saw the important features in case of esophagus, that it is lined by stratified squamous non-keratinized epithelium and the presence of submucosal glands. Then we moved on to stomach, where we saw the lining epithelium was columnar epithelium, and the glands, the cell variety and the appearance of the glands differ in the fundic and the pyloric region. And the muscular layer here as an additional oblique layer which is present, which is not seen in other parts of the GIT. So, with this we come to the end of today's session, and I would like to again thank the NPTEL Swayamprabha team and the coordinator Dr. Vijay Sagar sir for allowing me to give a presentation on today's topic. And I extend my gratitude to the gastroenterologist who provided me with the endoscopic pictures. So, with that we will end with a quote: "Learning is a curve which is very, very essential for growth. So, always keep learning." Have a nice day. Thank you.